If you're considering a panniculectomy, or if you've recently had this surgery and you're wondering what your recovery is really going to look like, especially if you're over 60 years old, I need to share some critical information with you that most surgeons don't fully explain during your preoperative consultation. I'm Dr. James Whittaker, a board-certified urologist with over 20 years of clinical experience, and today I'm going to walk you through exactly what happens during those crucial first 8 weeks after panniculectomy surgery, particularly focusing on the unique challenges that people over 60 face during recovery. This isn't going to be the sanitized version you get from surgical brochures. This is the real, unfiltered truth about what your body goes through, what complications can arise, what you can do to optimize your healing, and what realistic expectations you should have about your results and your quality of life after this major abdominal surgery. Before we dive into this important information, make sure you hit that subscribe button and turn on notifications so you never miss any of my evidence-based health content. And I want you to drop a comment below letting me know what country you're watching from, because I love connecting with viewers from all around the world who are seeking honest medical information to help them make better health decisions. Let me start by telling you about Margaret, a 62-year-old retired teacher who came to see me about 3 months before she was scheduled to have panniculectomy surgery. Margaret had lost 135 pounds over the course of 3 years through a combination of bariatric surgery, significant dietary changes, and a consistent exercise program. And she had done absolutely remarkable work transforming her health and her life. However, she was left with a large pannus, which is that apron of excess skin and subcutaneous tissue that hangs down over the lower abdomen. And in Margaret's case, this pannus extended down to her mid-thigh level. This excess tissue was causing chronic skin infections in the fold underneath the pannus. It was causing severe back pain because of the weight pulling forward on her spine. It was making physical activity difficult and uncomfortable, and it was significantly impacting her quality of life and her self-image after all the incredible work she had done to lose weight. Margaret's insurance company had approved a panniculectomy, which is different from a tummy tuck or abdominoplasty because panniculectomy is considered a medical necessity rather than a cosmetic procedure when the pannus is causing functional problems and recurrent infections. Margaret came to see me because she wanted to optimize her health before surgery to give herself the best possible chance of smooth recovery. And she also wanted honest information about what recovery would really be like because she felt like her surgeon had somewhat glossed over the details and made it sound easier than she suspected it actually would be. I spent about an hour with Margaret going through all the things I'm going to share with you today, and I helped her implement a pre-surgical optimization protocol that I truly believe made a significant difference in her recovery outcomes. Now, let me be very clear about what panniculectomy actually involves, because many people don't fully understand the magnitude of this surgery. A panniculectomy is the surgical removal of excess skin and fat from the lower abdomen, and it typically involves a long horizontal incision that extends from hip to hip, similar to a cesarean section incision, but much longer. The surgeon lifts up the abdominal skin and fat, removes the excess pannus tissue, and then pulls the remaining skin down and sutures it to the incision line. The surgery typically takes 3 to 5 hours, depending on how much tissue is being removed and whether any other procedures are being done simultaneously. During the surgery, you'll have drains placed, usually 2 or sometimes 4 drainage tubes that exit through small incisions and collect fluid that accumulates in the surgical space. And these drains typically stay in place for 1 to 3 weeks after surgery, depending on how much drainage you're producing. Now, here's what most people don't fully appreciate. This is major abdominal surgery that involves significant trauma to your tissues, disruption of blood vessels and lymphatic channels, cutting through nerves, and creating a large wound that your body has to heal. For a younger person in their 30s or 40s, the healing process is challenging, but their bodies generally have robust healing capacity and good physiological reserves to handle the stress of surgery and recovery. But when you're 62 years old like Margaret, or anywhere in that 60-plus age range, your body's healing capacity is significantly different, and you face unique challenges that require special attention and management strategies. Let me walk you through what happens during the first 8 weeks after panniculectomy surgery, week by week, and I'm going to tell you the things that no one bothers to mention in those preoperative consultations. Week 1 is absolutely brutal. There's just no way to sugarcoat this. And if anyone tells you otherwise, they're not being honest with you. You wake up from surgery in significant pain, despite being on strong pain medications. You have drains coming out of your body, collecting blood-tinged fluid. You have a long incision across your entire lower abdomen that's covered with surgical dressings. You're incredibly swollen and bloated, and you cannot stand up straight because the tissue has been pulled tight across your abdomen, and standing upright would put too much tension on the incision line. For the first several days, you'll be walking hunched over like you're 90 years old, shuffling slowly with assistance, and this hunched position is actually necessary to protect your incision from dehiscence, which is the medical term for the incision splitting open. The pain during week 1 is significant, and it's a different quality of pain than most people have experienced before. It's a deep, burning, tight sensation combined with sharp pains when you move certain ways. And the muscle spasms in your abdominal wall can be particularly intense and alarming. You'll be taking narcotic pain medication around the clock, and while this medication helps with the pain, it also causes constipation, which becomes its own miserable problem because straining to have a bowel movement puts tremendous pressure on your surgical site. You'll need to start taking stool softeners and potentially laxatives from day 1 to prevent this constipation, but many people don't realize this until they're already severely constipated, and then it becomes a real problem. Sleep during week 1 is nearly impossible. You can't sleep on your stomach, obviously. You can't sleep flat on your back comfortably because of the pulling sensation, and many people end up sleeping in a recliner or propped up with multiple pillows in a semi-reclined position. You'll need assistance with basically every activity of daily living during this first week, including getting in and out of bed, getting to the bathroom, showering, getting dressed, and preparing meals. Now, here's something critical that affects people over 60 much more significantly than younger patients. The physiological stress of major surgery causes a dramatic catabolic response in your body, meaning your body starts breaking down muscle tissue at an accelerated rate. Research shows that older adults can lose up to 5% of their total muscle mass in just the first week after major abdominal surgery, and this muscle loss happens primarily in your leg muscles and your core muscles. This rapid muscle loss is driven by several factors, including the inflammatory response to surgery, the stress hormone cortisol which floods your system, inadequate protein intake because you don't feel like eating, and physical inactivity because you're spending most of your time in bed or in a chair. This muscle loss is a serious problem because it significantly increases your risk of falls, it slows your overall recovery, it impairs your ability to regain functional independence, and it can trigger a downward spiral where muscle loss leads to more inactivity, which leads to more muscle loss. This is why I'm so adamant about implementing strategies to prevent muscle loss starting from day 1 after surgery, and I'll give you specific recommendations about this in a few minutes. Week 2 after panniculectomy surgery is usually when you have your first post-operative appointment with your surgeon, and they'll examine your incision, check your drains, and assess how you're healing. Most people still have their drains in place at the 2-week mark because they're still producing significant fluid output, typically between 50 and 100 milliliters per day from each drain. The pain during week 2 is usually somewhat improved compared to week 1, and many people are able to start transitioning from narcotic pain medications to non-narcotic options like acetaminophen and ibuprofen, although everyone's pain tolerance and recovery trajectory is different. You're probably starting to stand a little more upright during week 2, although you still can't fully straighten up without feeling like your incision is going to rip open. The swelling during week 2 is often actually worse than during week 1, and this surprises a lot of people who expect to see steady improvement every day. The reason swelling peaks around week 2 is that your lymphatic system has been significantly disrupted by the surgery, and it takes time for lymphatic channels to regenerate and for your body to establish new drainage pathways for interstitial fluid. You'll also start noticing during week 2 that you have areas of numbness or altered sensation across your lower abdomen, and this is because small sensory nerves were necessarily cut during the surgery. Some of this sensation will eventually return over the course of many months, but some areas may remain permanently numb or have that weird tingling sensation that feels like when your foot falls asleep. This nerve issue is something that really bothers some people psychologically because when you touch your own skin and you can't feel it normally, it creates a disconnect between your brain and your body that can be quite unsettling. Week 3 is often when drains finally come out. And while having the drains removed is a relief because they're uncomfortable and they limit your mobility and you have to constantly monitor them and empty them and measure the output, the removal of drains also introduces new concerns. Once the drains are out, fluid can accumulate in the surgical space, creating what's called a seroma, which is a pocket of clear yellowish fluid that builds up under the skin. Small seromas will often resolve on their own as your body gradually reabsorbs the fluid, but large seromas may need to be drained with a needle by your surgeon, sometimes multiple times over several weeks. During weeks 3 and 4, you're probably starting to feel like a human being again, rather than feeling like you've been hit by a truck, and you're regaining some functional independence, although you still have significant limitations. You can probably shower independently by this point, although getting in and out of the shower still requires caution. You can prepare simple meals for yourself, you can do light household tasks, and you're probably walking more normally, although still with some degree of hunching. However, week 3 and 4 is also when many people start experiencing significant psychological challenges that they weren't prepared for. The initial relief and excitement of having the surgery is wearing off. You're starting to see what your new body looks like as the swelling gradually decreases, and sometimes what you see doesn't match what you expected or hoped for. The incision is still quite red and angry looking. You're still very swollen. Your belly button might look weird if the surgeon had to reposition it. You have areas of numbness and irregularity, and you might be thinking, I went through all of this pain and suffering for this result? This is a very common reaction, and it's important to understand that you're seeing your body at probably its worst point in terms of appearance, and it will continue to improve significantly over the next several months. Week 5 through 8 is the period where you're making the transition from acute recovery to what I call the subacute recovery phase. And this is when many people make critical mistakes that can compromise their final results or lead to complications. By week 5 or 6, you're feeling quite a bit better, your pain is mostly resolved, you're moving around fairly normally, and you're eager to get back to your regular activities and routines. However, your tissues are still healing, and they're quite fragile. And if you do too much too soon, you can cause problems. Some people develop wound healing issues during this time frame where part of the incision breaks down or doesn't heal properly, creating an open wound that requires wound care for weeks or even months. This is more common in people who have risk factors like diabetes, smoking history, poor nutrition, or inadequate blood flow to the tissues. But it can happen to anyone, and the risk increases significantly if you're overexerting yourself or not following post-operative precautions. The other major issue during weeks 5 through 8 is the development of complications like infection, though this can happen at any point during recovery. Signs of infection include increasing redness around the incision, warmth in the tissues, increasing pain after it had been improving, fever or drainage of pus from the incision. And if you experience any of these symptoms, you need to contact your surgeon immediately because infections after panniculectomy can be serious and may require antibiotics or even surgical intervention to drain an abscess. Now, let me talk specifically about the unique challenges that people over 60 face during panniculectomy recovery, because this is information that's really important, but it's rarely discussed in detail. First and most importantly, older adults have significantly reduced physiological reserve compared to younger people, meaning your body has less capacity to handle the metabolic stress of major surgery and healing. Your cardiovascular system has to work harder to maintain blood pressure and perfusion to healing tissues. Your respiratory system has less capacity to handle the effects of anesthesia and pain medications that suppress breathing. Your kidney function is reduced, which affects how medications are cleared from your body and how well you maintain fluid and electrolyte balance. And your immune system is less robust, which increases infection risk. Second, older adults have much higher rates of pre-existing medical conditions that complicate recovery. Conditions like diabetes impair wound healing by affecting collagen synthesis and increasing infection risk. High blood pressure can increase bleeding risk and affects tissue perfusion. Heart disease limits your ability to tolerate the cardiovascular stress of surgery. Lung disease increases the risk of pneumonia and respiratory complications after surgery. And kidney disease affects fluid balance and medication clearance. If you have any of these conditions, your recovery is going to be more challenging and your risk of complications is higher than someone who doesn't have these underlying health issues. Third, older adults are much more susceptible to the muscle loss that I mentioned earlier. And this muscle loss can have devastating consequences for functional independence and quality of life. Research shows that while younger adults typically recover their pre-surgery muscle mass and strength within a few months after surgery, older adults may never fully recover the muscle they lose, and this permanent muscle loss contributes to frailty, increased fall risk, and declining independence. Fourth, older adults have increased sensitivity to pain medications and higher risk of adverse effects from narcotics, including confusion, delirium, falls, severe constipation, and respiratory depression. I've seen patients in their 60s and 70s who took the narcotic pain medications exactly as prescribed and developed significant cognitive impairment and confusion that was really frightening for them and their families. And in some cases, this narcotic-induced delirium can persist for weeks, even after the medications are stopped. Fifth, older adults have thinner skin and reduced skin elasticity, which affects healing and final aesthetic outcomes. Your skin doesn't bounce back and contract the way younger skin does, so you may have more residual laxity or irregularity in your final result compared to what a younger person would achieve with the same surgery. Sixth, older adults typically have less social support and may be living alone or may be the primary caregiver for a spouse. And this lack of adequate support during recovery is a major risk factor for complications and poor outcomes. You absolutely cannot manage the first 2 weeks of recovery after panniculectomy by yourself. You need someone staying with you around the clock to assist with all your basic needs. And if you don't have family members who can provide this support, you need to arrange for paid caregivers or consider going to a short-term rehabilitation facility. Now, let me give you the specific strategies that I implemented with Margaret before her surgery and during her recovery that I truly believe made the difference between a difficult recovery and a successful one. First and most important is pre-surgical nutritional optimization, particularly focusing on protein intake and micronutrient status. I had Margaret increase her protein intake to at least 1.2 grams per kilogram of body weight per day for the entire month leading up to surgery, which for her meant about 90 grams of protein daily. This higher protein intake helps build up your protein stores before surgery, so you have reserves to draw on during the catabolic stress of surgery and early recovery. I also had Margaret start taking a high-quality multivitamin, vitamin D supplementation to get her blood level above 40 nanograms per milliliter, vitamin C supplementation at 1,000 milligrams twice daily because vitamin C is critical for collagen synthesis and wound healing, and zinc supplementation at 30 milligrams daily because zinc deficiency impairs wound healing. We also optimized her iron status because she had borderline low iron stores, and iron is necessary for oxygen delivery to healing tissues. Second, I had Margaret work with a physical therapist for 4 weeks before surgery to improve her core strength, her leg strength, and her cardiovascular fitness as much as possible. Going into surgery with better baseline fitness gives you more reserve capacity and helps prevent some of the muscle loss and functional decline that happens after surgery. The physical therapist taught Margaret specific exercises she could do in bed during the immediate post-operative period to maintain muscle activation without compromising her surgical site. Things like ankle pumps, quad sets, gluteal squeezes, and arm exercises with light resistance bands. Third, we created a detailed post-operative nutrition plan focusing on maintaining adequate protein intake even when Margaret didn't feel like eating. I recommended protein shakes that provided at least 30 grams of high-quality protein and could be sipped slowly throughout the day. And I emphasized the importance of getting at least 80 to 100 grams of protein daily during the entire 8-week recovery period to minimize muscle loss and support tissue healing. Fourth, we implemented an aggressive bowel regimen starting the day of surgery to prevent the constipation that's inevitable with narcotic pain medications and reduced mobility. Margaret took a stool softener twice daily. She used a gentle stimulant laxative every other day, She took magnesium citrate supplement, which has a mild laxative effect, and she prioritized hydration with at least 64 ounces of water daily. This proactive approach prevented the severe constipation that causes so much misery for many post-surgical patients. Fifth, I recommended that Margaret use narcotic pain medication only for the first 4 to 5 days, and then transition as quickly as possible to non-narcotic options like scheduled acetaminophen and ibuprofen, supplemented with ice packs and positioning for comfort. This early transition off narcotics reduced her risk of cognitive side effects, constipation, and dependence, while still providing adequate pain control. Sixth, we implemented what I call progressive mobilization, starting from day one after surgery, which means gradually increasing physical activity in a structured way to prevent complications like blood clots and pneumonia, while also minimizing muscle loss. On day one after surgery, Margaret sat up in a chair 3 times for 20 to 30 minutes each time and walked to the bathroom with assistance. On day two, she sat up more and took short walks around her room every 2 to 3 hours. By day 3 and 4, she was walking in the hallway multiple times per day, gradually increasing her distance. By week 2, she was taking 2 to 3 short walks outside every day. By week 4, she was walking 20 to 30 minutes twice daily. This progressive increase in activity helps maintain muscle mass, improves circulation to promote healing, prevents blood clots, improves lung function to prevent pneumonia, and helps with psychological well-being. However, it's absolutely critical to avoid any activity that increases intra-abdominal pressure during the first 6 to 8 weeks, which means no lifting anything heavier than 10 pounds, no reaching overhead, no pushing or pulling heavy objects, no abdominal exercises or core work, and no high-impact activities. Violating these precautions can cause your incision to split open or can cause a hernia to develop, so you have to be very disciplined about following restrictions even when you're feeling better. Seventh, we address the lymphedema and swelling that's inevitable after panniculectomy surgery. Margaret wore an abdominal binder continuously for the first 6 weeks, except when showering, and this compression garment helps minimize swelling, provides support to the surgical area, and makes movement more comfortable. She also did gentle manual lymphatic drainage massage starting at week 3, which involves very light pressure massage strokes that encourage lymphatic fluid to drain from the swollen tissues. Some people benefit from working with a certified lymphedema therapist who can teach proper massage techniques and may recommend additional interventions like compression therapy. Eighth, we were very proactive about scar management starting around week 4 when the incision was fully closed and healed. Margaret started using silicone scar sheets or silicone gel applied to the incision twice daily, and she did gentle scar massage once the incision was no longer tender. These interventions have good evidence for improving scar appearance by keeping the scar hydrated, reducing collagen overgrowth, and preventing the scar from becoming thick, raised, or hyperpigmented. Now let me come back to Margaret's story and tell you how her recovery actually went, because I think it's helpful to hear about a real patient's experience. Margaret's surgery went smoothly, and she had about 6 pounds of excess tissue removed, which is a fairly substantial amount. Her immediate post-operative course was difficult, as expected, with significant pain and limited mobility during that first week. However, because she had optimized her nutrition and fitness before surgery, and because she was so diligent about following the recovery protocol we had developed, she avoided major complications. She did develop a small seroma around week 4 that required drainage twice in the surgeon's office, but it eventually resolved. She was able to discontinue narcotic pain medication by day 5 and managed her pain well with scheduled acetaminophen and ibuprofen. She maintained her protein intake at about 90 to 100 grams daily throughout recovery by relying heavily on protein shakes when she didn't feel like eating solid food. By the 8-week mark, Margaret was feeling remarkably well. She was walking 3 to 4 miles per day. She had returned to most of her normal daily activities, and she was thrilled with how her body looked now that the excess pannus was gone. She had lost some muscle mass despite our best efforts. We estimated about 3 to 4% based on her strength testing, but this was much less muscle loss than typically occurs in patients her age, and she was working on rebuilding that muscle through progressive resistance training. Her incision was healing beautifully. It was a thin, flat line that was still slightly pink but fading nicely. She still had some areas of numbness across her lower abdomen, but this didn't bother her much. She said the entire experience was challenging and more difficult than she expected, but absolutely worth it for the improvement in her quality of life and her ability to move comfortably without that heavy pannus pulling on her body and causing chronic pain and skin problems. Now, let me address some of the complications that can occur after panniculectomy that you need to be aware of, because informed consent means understanding not just the best case scenario, but also what can go wrong. Wound dehiscence, where part or all of the incision splits open, occurs in about 3 to 8% of panniculectomy patients and is more common in people with diabetes, obesity, smoking history, or poor nutrition. Small areas of dehiscence can often be managed with wound care and will heal by secondary intention, meaning the wound gradually fills in with new tissue from the bottom up, but this can take many weeks or months. Large dehiscence may require surgical revision to close the wound. Infection occurs in about 5 to 10% of patients and can range from superficial skin infection treated with oral antibiotics to deep abscess requiring surgical drainage and intravenous antibiotics. Seroma formation, which I mentioned earlier, occurs in about 20 to 30% of patients and usually resolves with aspiration and compression, but occasionally requires surgical intervention if it persists or becomes very large. Blood clots, including deep vein thrombosis and pulmonary embolism, are serious complications that occur in about 1 to 2% of patients undergoing panniculectomy, and the risk is higher in older adults, people with obesity, smokers, and people with certain genetic clotting disorders. This is why early mobilization after surgery is so critical. Walking as soon as possible reduces blood clot risk dramatically. Some surgeons also use blood-thinning medications in high-risk patients during the immediate postoperative period. Nerve damage can occur during surgery and may cause areas of permanent numbness, altered sensation, or in rare cases, chronic neuropathic pain. Most sensory changes improve over 6 to 12 months, but some residual numbness is common. Scarring issues including hypertrophic scars, keloids, or wide scars can occur in some people based on their genetic predisposition to abnormal scarring and how well they follow scar management protocols. Contour irregularities, asymmetry, or residual laxity are aesthetic complications that may require revision surgery to correct if they're significant enough to bother the patient. Let me also address the financial aspect of panniculectomy because this is a significant consideration for many people. If your panniculectomy is being done for medical necessity rather than purely cosmetic reasons, meaning you have documentation of recurrent skin infections, rashes, or functional impairment from the pannus, then it may be covered by your insurance. However, insurance coverage doesn't mean it's free. You'll likely have significant out-of-pocket costs, including your deductible, coinsurance, and any cost that the insurance company doesn't deem medically necessary. Even with insurance coverage, many patients end up paying $5,000 to $15,000 out of pocket. If your insurance doesn't cover the procedure, or if you don't qualify for medical necessity, then you're looking at paying the full cost out of pocket, which typically ranges from $15,000 to $30,000, depending on your geographic location, the surgeon's fees, the facility fees, and the complexity of your case. You also need to factor in indirect costs like time off work. You'll need at least 4 to 6 weeks off work for most jobs and possibly longer if your job involves heavy lifting or physical labor. You'll need help at home for at least the first 2 weeks, which may mean hiring caregivers if you don't have family support. You'll need specialized supplies like abdominal binders, wound care supplies, protein supplements, and medications. These costs add up and they're important to consider when making your decision about whether to proceed with surgery. Now, let me give you some specific recommendations about how to decide if panniculectomy is right for you, particularly if you're over 60 years old. First, you need to be at a stable weight for at least 6 to 12 months before considering panniculectomy. If you're still actively losing weight, your tissues are still changing, and you should wait until your weight has stabilized before having excess skin removed. Second, you need to have realistic expectations about what this surgery can and cannot do. Panniculectomy will remove the excess hanging skin and improve your body contour. It will eliminate the skin problems caused by the pannus It will likely improve your ability to exercise and be physically active, and it can significantly improve your quality of life. However, panniculectomy will not give you a flat, perfect stomach. It will not eliminate all the loose skin. You'll have a long, permanent scar. You'll have some areas of numbness or altered sensation, and you may have some contour irregularities or asymmetry. You need to decide if the benefits outweigh these limitations and the risks of surgery. Third, you need to honestly assess your health status and your ability to tolerate major surgery. If you have significant medical problems that are not well controlled, if you have advanced heart or lung disease, if you're actively smoking, if your nutritional status is poor, or if you have limited social support, then you're at much higher risk for complications and poor outcomes, and you may need to reconsider whether surgery is appropriate or whether you need to first optimize these issues before proceeding. Fourth, you should meet with multiple surgeons before choosing who will perform your surgery, because surgeon skill and experience matters tremendously for outcomes. Look for a board-certified plastic surgeon who has extensive experience specifically with panniculectomy and body contouring after massive weight loss. Ask to see before and after photos of their previous patients. Ask about their complication rates, and make sure you feel comfortable with their communication style and their willingness to answer your questions. Fifth, make sure you have adequate support in place for recovery, because you absolutely cannot do this alone, especially in that first 2 weeks. If you don't have family members who can stay with you and help you, you need to arrange for professional caregivers or consider a short-term stay in a rehabilitation facility. Trying to manage recovery by yourself is dangerous and significantly increases your risk of complications. Sixth, implement a pre-surgical optimization program like the one I described for at least 4 to 6 weeks before surgery. Work on improving your nutrition, particularly your protein intake and your micronutrient status. Work on improving your fitness level within the limits of what you're able to do. Optimize the management of any chronic health conditions. Stop smoking if you smoke. And meet with your primary care physician to get medical clearance for surgery. Finally, I want to emphasize that panniculectomy is major surgery and it should not be taken lightly, but for the right patient, with the right indications and the right preparation and support, it can be a life-changing procedure that dramatically improves quality of life and functional capacity. The decision to have panniculectomy is deeply personal, and it needs to be based on your individual circumstances, your health status, your goals and expectations, and your willingness to commit to the challenging recovery process. If you've had massive weight loss and you're left with excess skin that's causing medical problems and limiting your ability to enjoy the benefits of your weight loss, then panniculectomy may be an excellent option for you. But go into it with your eyes wide open, with realistic expectations, with excellent preparation, and with a strong support system in place. I hope this video has given you valuable and honest information about what panniculectomy recovery really looks like, especially for people over 60. If you found this helpful, please give this video a thumbs up because it helps the YouTube algorithm share this information with other people who need to see it. Make sure you're subscribed to my channel with notifications turned on so you don't miss future videos where I'll continue sharing evidence-based health information that you can actually use to make better decisions about your health and medical care. Drop a comment below and let me know what country you're watching from, and let me know if you've had panniculectomy or other body contouring surgery, or if you're considering it and what questions you still have. I read every single comment, and I love hearing from you and learning about your experiences. If there are specific topics you want me to cover in future videos, let me know in the comments and I'll do my best to address them. Thank you so much for watching. Take care of yourself, and I'll see you in the next video.